Good morning, good afternoon, good evening, colleagues. Welcome to our webinar today. We are very pleased to welcome you to this event. This webinar is hosted by the Network for Improving Quality of Care for Maternal, Newborn and Child Health. My name is Olive Kokeman. I am the Learning Documentation Lead for the network, and we're delighted to be here today with our colleagues and friends from Malawi to share this really excellent collaboration, this initiative to improve the quality of care in facilities. And so today we have three parts. In a moment, I'm going to hand you over to our colleague Hester, who will introduce all our partners from Malawi. We have part one, which is presentation lessons from Malawi, and we will hear from the Ministries of Health, and we will hear from the Medical Council of Malawi, who's speaking on behalf of the three professional bodies we have present here today. In part two, we'll have a questions and answers session. And the presenters from part one will join us with two further colleagues for that session. Now, please type your questions in the chat box, and for that questions and answer session, we will be delighted to pose them, of course, at that moment in time. Okay, so we're very excited about this event today. I'm going to be handing you over to Mr. Hester Nayasula. He's the Executive Director, White Ribbon Alliance Malawi. And Hester and his team at White Ribbon Alliance have been working very closely on this concerted effort to streamline the work of regulatory bodies to establish a standardized approach for the inspection of health facilities. This helps to reduce the burden on the facilities, as well as delays to patient care that can be incurred due to the demands of inspections. We think this is a really novel, this fantastic example of collaboration of stakeholders. And we'll hand over to you now, Hester. Please take this forward and explain the background to the work and introduce your colleagues. Over to you, Hester.
Thank you so much, Olive. So today, White Ribbon Alliance, we are very, very excited that we can showcase the integrated inspection tool for the three regulatory bodies in Malawi. It has come a long way. It was a wish for the regulatory bodies to work together, but there was no tool that could guide this work. And we're happy we supported this process. As White Ribbon Alliance, we are advocates. We listen from the women, we listen from the health workers. And one of the challenges that was coming out was on the way the inspections were done, the feedback system, and also the coordination. So coming from that front and listening to the voices from women, from the What Women Want campaign that we did, and also the interviews that we did with the midwives who provide care to pregnant and lactating women, we took it upon us to work with the Ministry of Health, the Quality Management Directorate, and also the three regulatory bodies to come up with the integrated inspection tool. And today we'll hand over to the Quality Management Directorate team and also the regulatory bodies themselves to walk us through the presentation. So I'm happy to introduce Dr. Bongani Chikwapulo. Dr. Bongani is the head of norms and standards in the Quality Management Directorate of the Ministry of Health, Malawi. And I'm also happy to introduce Mr. Richard Novi, a very experienced person. He is the Assistant Registrar for the Professional Practice for the Medical Council of Malawi. And then also Mr. Selemani Kondowe, who is the Senior Quality Management Officer in the Quality Management Directorate of the Ministry of Health. The three will make a presentation. We'll start with Dr. Bongani, and then Mr. Richard will come in, and then that's when Mr. Selemani will now present on the tool itself and how it is designed. So over to you, Dr. Bongani, to take it up. Thank you.
Thank you very much, Hester. So I'll be presenting the work that Ministry of Health through Quality Management Directorate did with the three regulatory bodies in Malawi to come up with an integrated inspection tool. So I'll take you through the process that we did at that particular time. As a country, our goal is to achieve quality care as we're implementing universal health coverage, and this care has to be equitable and affordable. Hello, I think the screen is not moving. Yeah, thank you very much. So, as I was saying that the care has to be equitable and affordable to Malawians. And within our constitution, the regulatory bodies are mandated to ensure that each facility is offering minimum quality of care to assure patient safety. And in the health space in Malawi, there are three main regulatory bodies: the Medical Council of Malawi, the Nurses and Midwives Council of Malawi, and the Pharmacy and Medicines Regulatory Authority of Malawi. And during the situation analysis for the health sector strategic plan, it was noted that there was a weak regulatory framework in the country. May you go to the next slide, please? And this was coming in because of the sporadic inspections that the regulatory bodies were doing. Actually, they were not able to achieve their mandate of inspecting at least one facility each year. And at that particular time, there was also increasing incidence of bogus providers. In terms of enforcement of their regulatory functions, it was so noted at that particular that there was no proper coordination, because each facility would go to each regulatory body will go to the facilities alone, and in some cases, this was contributing to disruption of health care services. And when we also noted that during the inspections, there were areas that the regulatory bodies were collecting similar information, and this was resulting into duplication of efforts, and also leading to high operational costs as each regulatory body would go along to the facilities. So coming from this background, as a ministry, we thought of facilitating the integration or collaboration among the regulatory bodies in order to improve coordination in terms of enforcing regulatory functions among the regulatory bodies in the country. Next slide, please. So just going through the process that we went through. So initially, this discussion started within the Quality Management Directorate, and considering that the sensitivity of the work that we're trying to do, because regulatory bodies are a watchdog to the Ministry of Health.
Dear Pongani, it looks like your camera is stalling. Maybe if you turn off your camera for a moment, we will hear.
Procedure management, and they support it. Yeah. So, can I?
Yeah, dear Pongani, it's going very slow. If you turn off your camera, maybe we can hear the sound, and there'll be less disruption. Will we try that for a moment? Thank you. And then have we lost Pongani? Oh dear. Okay, we've lost him for a moment. Solomon, would you like to continue until, oh, Dr. Magani's back, I think. Here we go.
It's back, yeah.
Wonderful. Okay. Wi-Fi is not always our friend.
So apologies for that.
Not at
I
all. Off you
lost-
go.
Yeah, so after we engaged the studio management, we got their blessings and we started engaging the three regulatory bodies. It was easy for them to buy in because this wasn't something that they had been doing before. They were informally engaging each other, and this process was just to formalize that process. So we started the process of looking at their tools, looking at similarities within the tools, looking at areas that we can be able to harmonize. And we developed one single tool, and this was tested. Initially, we uploaded this tool on ODK, and when we tested it, it was not giving the results that we anticipated. We changed the electronic tool to a Google Sheet. After being satisfied on how the outlook of the tool, the regulatory bodies went ahead to pilot the tool, and they went to up to 51 facilities. After that process, we further reviewed the tool, improved it based on the issues that came out from the pilot. And at the end of the process, we present to the board members of the three regulatory bodies. And the board members are a governance structure for the regulatory bodies, and they are responsible for approving anything that is happening within the regulatory bodies. And we had a good response, and the tool was eventually endorsed by all the three regulatory bodies. Next slide, please. Yes. Just explaining more about the tool. So the tool is in a number of sections. My sections, health management information systems, inpatient departments, so focusing on maternal and child health, antenatal care, labor wards, nursery, pharmacy department. It has also a summary sheet. So the summary sheet will show you the summary of the results of the different areas that are inspected. And it also has got a decision the inspectors to make based on the results from the inspection. Next slide. Yeah, so that's a summary sheet from one of the facilities that was inspected. And one thing to point out, the determinations from the inspections are guided by the different acts from this. And this is important to look at where the areas that the facilities are struggling, so that they can be provided support. Next slide. So considering that this is a unique, this is at Ministry of Health, and Ministry of Health being a provider of services, we thought that we had to clarify the role of each stakeholder. For the regulatory bodies, their role was to make the inspections, and also provide joint activities. In the short and medium, regulatory bodies will also be expected to be mobilizing resources from their traditional partners, so that they can so that the joint inspection directorate, our role in this process is after that. So our role is to support the facilities to ensure that they close the gaps. They close the gaps that are identified during the inspections. As a country, as a country and as KMD, we are championing accreditation, and the minimum standards that have been enforced by the regulatory bodies are a level at the entry level into accreditation process, and this is why we were interested in this work, to ensure that at least each facility and each facility can be able to assure Malawians, so that so that they can they're able to receive the minimum level of care possible. The other role is also to support in mobilizing of resources, engaging donors, so that they can be able to support the joint inspection. Thank you very much. I hand over to my colleague, Richard.
Thank you very much for the invite. Richard Ndovi, Medical Council of Malawi. I'll be presenting on the experiences. So, since the inception of the concept of integrated inspections, we conducted the inspections of the facilities starting from 22nd March 2021 to 2nd April 2021. And as alluded before, 51 health facilities were visited, 2 central hospitals, 14 district hospitals, 11 community hospitals, and 24 health centers. And there were 4 teams. Each team had 6 inspectors, including co-opted members. So you see 51 we have almost 30 districts, so we have more district hospitals as well. But we managed to visit 14, and health centers, we have also more health centers within Malawi, and we have 4 central hospitals. So that's how these are already accredited facilities established. I can explain to say we have different types of inspections. Once the government or a private practitioner is setting up a facility, we do what we call initial inspections. And then we have inspections which we are doing now, like integrated. These are scheduled and routine inspections. And we have also inspections when we have received an issue regarding a facility in terms of infection prevention or any other. We also respond to such inspections. So each team had 6 inspectors, including co-opted members. Co-opted members, usually these are members of the professional associations or practitioners within the district. The other, yeah. So what worked? Holistic inspections. So as the target for the integrated inspections were these big hospitals and health centers, all sections of the facilities were inspected. So what it means is the pharmacy team will concentrate on the practice of the pharmacy, including the drugstores. And the nursing and the medical council team will also concentrate in terms of inspecting the whole facility, from the infrastructure, equipment and supplies, availability of guidelines, and another treatment guidelines, and the availability even in terms of the human resources themselves, whether they are registered or not. So that's how we approach in terms of holistic. And the facilities were visited once, as opposed to each regulatory bodies visiting each health facility. So what we are communicating here is we have 3 regulatory bodies, and we have our own acts, And then we draw programs, annual programs, according to our strategic plans. So obviously, the Medical Council will have our own program, and the Nurses Council, as well as the pharmacy. So sometimes that's what they were saying, to say previously we would go to a district hospital, and a month later another regulatory body will go to the same district hospital, and a month later maybe the pharmacy board will also go to the PMRA, will also visit the same hospital. So it was cumbersome and burdensome. But conducting these inspections using integrated approach has eased up the burden to the facilities, and even reduced the inspection fatigue within the facilities. A lot of health facilities were reached in short time using the available resources. And use of cooperated members increased the pool of inspectors, knowing that we have many facilities and district hospitals and health centers in the rural areas. If we target the district, suppose it has 30 health facilities, it means we needed to form up teams. Then you find the numbers from the regulatory bodies of inspectors are not adequate. So that's when we involve the pool of cooperated members. And we were also sharing good practices in terms of approach to inspections. We regulate different scopes. So going together, obviously, we were sharing good practices in terms of regulating the scopes among the practitioners, as well as other requirements for the health facility in terms of equipment, infection preventions, and the guidelines, and the disposal of medical waste, availability of theater lists, as well as diagnostic sets. Next. So, however, this is it's not so much a challenge, but there could be still some problems. We have issues related to different activity calendars. We go by the government year, but as I alluded to earlier, to say each regulatory board has its own action plan in terms of from their strategic plan. So that requires collaboration within the regulatory bodies. So this type of visits improves inter-regulatory collaboration rather than the previous, where sometimes we have inter-regulatory antagonisms in terms of decision making. And then we have also inadequate vehicle for inspections. Usually the regulatory requirement is that every health facility has to be visited once in a year to enforce the standards. The whole issue is about public protection, and also to create the enabling environment for the practitioners in the hospital. But sometimes we are bogged because of the shortages or shortage of vehicles, as well as old vehicles, and then it makes our job very difficult. Few available inspectors, we have already said that, to say we have few available inspectors. Our plan is to increase our visibility in all regions. We have 3 regions: the south, the central, and the north. So with the few inspectors, obviously, even we increase the visibility, they cannot be enough. So we cooperate members to cover the gaps. So there could be doctors, nurses, and pharmacists from professional bodies, as well as from other hospitals. So once we cooperate members, then they become part. We always call them, plan with them to participate in the inspections. So, however, this also comes with another challenge: inadequate orientation. Suppose we get co-opted members who have never conducted a regulatory inspections, not just supervision, supportive supervision. We do both supportive as well as we use a regulatory eye when we are visiting them. We are visiting the facility. So obviously we have our own code of conduct, how you ought to behave, as well as how you ought to conduct as you are doing your inspection. You need to have the knowledge of what you are going to inspect, and you also adhere to the code of conduct in terms of respect for person as well as the integrity of the hospital itself. So that requires orientation and understanding the checklist itself. So obviously many who did not go through the orientation, and then we had to train them on the job. Apart from orientation of the two, they also require orientation of the code of conduct as alluded to. Thank you very much. I hand over to a Selemani Kondowe.
Thank you, Richard. I'm Selemani Kondowe from Quality Management Directorate, and I will take you through the joint inspection 2 that we've been talking about. Yeah, so let me share. So this is an Excel-based assessment 2, inspection 2, that was jointly worked on by all the regulatory bodies, and we can put it on, we usually put it on Google online sheets so that the inspectors collaborate well during the inspection. It's an easy way of consolidating the information together when at the facility. So the tool, as I said, is Excel-based. It has about 5 components. So it has the general information area and the management area. And then we have the departments, the roles itself. All these are the departments. And then, as Bongan said, we have also the summary sheets. The summary sheet summarizes all the assessments in terms of scoring from the various sections. And then at last, we have the decision sheet, which now has just filtered some very critical areas which the facilities have to ensure that those things are available. So these are the very critical areas. So just a quick through the two. So this is the general information about the facility. And then in the management too, Bongan talked about the health information system and the senior management. So this information assessment can be found in the management sheet. So in terms of scoring, we are using compliance rating, where we have C means compliant, and PC means partially compliant, NC means not compliant, and NA means not applicable. So if the inspectors are satisfied with that kind of criteria, the evidence that is produced, it is compliant. If they are not fully convinced, it is partially. And if they are not convinced at all, it is not compliant. So yeah, so we have all those elements. Of course, there's weighting somewhere, so that because others, as I said, they are critical criteria, so they are given high weight on the critical criteria. So like here we have issues that are highlighted, like in the pharmacy, we have air conditioners. If the pharmacy doesn't have those, it means the drugs are not safe in that pharmacy room. So it is a critical criteria and it's given a high weight. And then there is this one, registered personnel in the pharmacy. Without that, it means the drugs cannot be well kept or being issued to the pharmacy personnel. So we have those weights, as you can see here, under this section. Most things are compliant, but only these two things are not compliant, and then the facility scores 15, despite that you have so many things that are compliant, which is 100%. So we have given way to those. All the regulatory bodies agreed to weigh them differently because they impact differently on the safety of the patients and all the supplies. So this rating applies to all the sections. All the sections are like that for particular departments, and then we have the summary sheet which Bongani talked about. So for this is St. Gabriel Mission Hospital. This was that assessment, and where you have zeros, it means assessments were not done or the service is not provided, and this is the average. So we have at last the final decision where we have filtered some critical components which the inspectors will ensure that, as I said, we ensure that the elements are considered. So we have options there. We have about 10 areas. Registered facility pharmacy of the institution is registered, so it's facility registration, pharmacy registration, running water incinerator, and the others down there. And for each element, we have, if it is partially compliant, not compliant. So we have drop down options. So the joint the inspectors will decide what to do on that element. So they may decide to give them 2 weeks, 1 week, 3 months, or 3 weeks. Yes, they may choose the inspectors. Breath as is raw is to ensure that the gaps that are identified here are worked upon, and they work closely with those facilities to ensure that they close these gaps. So that's their role, but inspection role is left to the inspectors as per the Act. So that's how the two works in brief. Thank you so much.
Thank you so much, Dr.
Thank you.
Saran. That was a very useful walkthrough. I'm going to bring back up the slides and over to you, Hester.
Thank you so much. So that's a tool and the advantages that we have seen. And at the moment, we are now open to questions. We already have a lot of questions that are there. But before we get to that, I would like to introduce two more representatives from the regulatory bodies. I'm happy to introduce Ms. Chris Chulu, available here. So Ms.
Esther, we seem to have lost your sound. So let me just take over while we recover you. So we're very welcome to Ms. Chrissy Chulu. Chrissy is the Chief Medicines Inspection
Chris Chulu is Medicines Regulatory Authority Officer. And have you lost?
Continue, Hester. Yeah.
Thank you so much. And then we have Ms. Mtondera Montari. She is with the Nurses and Midwives Council of Malawi, and she is the inspection and investigation specialist. So welcome the two of you to this discussion. And I know you'll be answering the questions here. And already I have the first question that goes to Ms. Chrissy Chula. Please tell us more on how has the integration improved the reporting and the feedback systems for the regulatory bodies? Would you want to talk to the reporting and the feedback system that has improved through this integrated tool? Over to you, Ms. Chrissy.
Thank you so much, Mr. Hester. The integrated inspection with the focus to the tool, we noted that it can enhance real-time reporting. As it has been presented, we've noted that it provides specific items for various specific sections of areas that are supposed to be inspected, and it also compiles the results and it provides regulatory decision based on the results after the inspection itself. So having provided this real-time reporting, and if this tool could be accessed by inspectorate managers within different regulatory bodies, it will provide for real-time advice as well as regulatory action in terms of whether there is need to provide further guidance to each of the inspected facilities based on the results that have been obtained after the inspection itself. And the other issue is that the tool itself, the integrated inspection itself, it limits the time for feedback mechanisms, because traditionally when there is one regulator who is conducting inspection, would go to conduct the inspection, there would be some other areas that have been noted, but maybe not necessarily within the jurisdiction of this regulator. So it would demand that this regulator goes back and liaises with the other regulator, and that takes time. But when you are doing this integrated inspection, all of our regulators are there, and you are able to consult one another in terms of specific advice that might be needed in a specific area. So there's also real-time feedback that is provided to the inspected facilities. And the integrated inspection through the tool itself as feedback, each hospital management is appraised on the outcome, on the results themselves during the exit meeting that is conducted. And these results, because this tool is an integrated tool, they are encompassing, they are touching on all the areas that are responsible for all the regulators. So this gives ample time to the hospital management to take note of the non-compliances that have been observed, and possible actions that would be done in order to address those, such that all the advice is obtained at that one particular meeting, other than when there are some disjointed inspections. It gives a lot of work and time, a lot of burden to the hospitals themselves. But with this integrated inspection, all the issues will be handled as the one, because they are from the same report. So this it promotes the feedback, it promotes reporting, and it promotes working on the non-compliances effectively by the facilities that have been inspected. And by this way, the procedure itself becomes so efficient. Thank you.
Thank you so much. Olive, are you ready for the next question?
Yes, yes, we have a question. Welcome, Ms. Montondera Montali. Welcome. We're so pleased you're here with us today. And you know, on behalf of the Council, Nurses Midwives Council of Malawi, we'd like to ask you, you know, just as we've heard from Chrissy, this tool has seemed very efficient, and it the intention then is to adopt this tool moving forward, joint collaboration. Can you describe a little bit about what steps are needed to make this operational and more sustainable moving forward, so this could continue this collaboration? Over to you, Montserrat.
For this integrated inspections to be operational and more sustainable, there is need for commitment by all the regulatory bodies to ensure that they create time and space in their annual work plans to ensure that the programs don't clash with each other, because there is need for all the regulatory bodies to be available for the activity. So there is need for collaboration and proper commitment from all the regulatory bodies. And there's also need for the regulatory bodies to ensure that in their annual budget, they spare some funds for the activity, not just to rely on the donors, in order to ensure that there's sustainability. And also on top of that, the regulatory bodies can come together and maybe source funds from donors as well to ensure that this program is operational and sustainable. And luckily, the boards have shown interest in that. They have approved the tool. So I think it's just more to lobby from the boards, maybe, so that they can also be able to approve integrated budgets to ensure that this doesn't die a natural death for sustainability's sake. Over to you, Olive. Thank you.
Thank you. Thank you very much. As you say, yeah, this doesn't die a death. There's very important steps to be taken in terms of resourcing, yeah, and further commitment. Hester, you have further questions. We'd like to bring in our presenters as well. And there's questions that are coming up in the chat box, as well as question you have, Hester. Can I hand over to you now?
Thank you so much. Ms. Mtondera just touched on the resource mobilization part. I wanted to ask Bongani and Richard to understand how the donor community has reacted to this new approach, and how the three regulatory bodies and also the Quality Management Directorate will help in sourcing funding for the joint inspections moving forward. How are you going to engage the donor community, and what has happened so far? Over.
Thank you very much, Hester. So the plan is that we have to engage the health donor group in country, and that has not been done yet. That said, we've been engaging. I think the discussions that we've had with individual donors has had some. We have had positive feedback. What donors like is that this approach is bringing in efficiency. As you're aware that we are working in a low resource context, and an approach that is bringing efficiency is usually supported by donors. So we've had some positive feedback from the individual donors that we've discussed with on this. But I think we'll be engaging them formally through our health donor group. I'll hand over to my colleague Richard to also weigh in on this.
Thank you very much, Dr. Ongani. Yeah, as previously alluded to by Dondera, as regulatory bodies, we have our sources of funding. And the main source of funding is subscription from annual subscriptions from practitioners, and fines and penalties. So sometimes we are also supported by the government itself, about a quarter of the funding, which we appreciate. So we also make annual plans. So usually we'll make plans to inspect facilities within a year, depending on the financial muscle we have for that year. And it is dependent on the plans that we envisage to be making collaborated efforts, plans with our fellow regulators like the Nurses and Midwives Council and the PMRA. In terms of the donor, this, instead of going solo, knocking at doors of different donors, this will give us an opportunity to write a comprehensive proposal, and then hoping that we will have appropriate response, and that will make our life easier, because all the three of us will be working as a unit in terms of inspections, and then be supported accordingly and provide real-time feedback as alluded to by the PMRA representative, Mrs. Chu. Thank you. Hello.
Thank you so much. Thank you so much. Do we go to the next set of questions? Would you want to guide on this?
Excellent. Thank you, Hester. Thanks to the panelists so far for providing very clear answers to all the questions. We're looking in the chat box, and there's a lot of appreciation for this presentation and for sharing the tools and for this collaboration. I think important questions coming up in that once you have completed the accreditation, what happens then? What are the follow-up actions? You know, in terms of the fact that you're working together as a collaboration. So which agency takes responsibility for follow-up? How do you do that together? I guess we start, in terms of the follow-up actions, we start with you. Richard, would you like to answer that question to start with?
Yes. Once we have done the inspections, obviously we do a next briefing. We brief the management on our findings. And then there are certain issues which have to be done there immediately, which we demand that things should be done immediately since we have been at the facility. Many issues to do with infection prevention and other things in terms of things which will put the patients to harm, which will expose the patients to harm. And then we also write a report. So this obviously will be writing the report jointly. Which is very possible, joint report writing, and share with the appropriate stakeholders. What we mean is including the proprietor of the facility, the management at the facility itself, and then what we demand from them giving us an action plan on certain things, because there are certain things, as I said, that maybe we may say we are giving you a month to attend to this, or a week, and there are other things which the institutions and proprietors may demand to say, I think it may take a 6 months or 5 months, depending on the gravity of the issue, mainly if it's infrastructure. So that's how we do. And once they have responded in terms of providing us with the action plan, then we do follow-up visits to say we agreed that in 3 months we will have you will attend to this. Then we usually envisage to conduct follow-up visits, and obviously that will demand other resources. But for us to enforce that, those follow-up visits are important, and they are updating each other. So in that way, it means we are collaborating and also negotiating with the proprietor to achieve whatever we have found. There are certain times that's the worst thing which can happen, maybe to a facility, maybe a small facility like a health center or a department, is if it's so waste, then usually we close. But the closure is not usually immediate. We still go through negotiations, and if we feel the environment is so harmful to the patients, then we have that mandate to close irrespective whether it's a government facility or a private sector. So in this case, the decision will be made in unison with the other regulatory bodies. Thank you.
Thank you very much, Richard. Hester?
No, it seems it's Bongani who wants to speak. Bongani, you want to come?
Please, Bongani, please come in.
Yes, thank you very much. And from the Ministry of Health side, we one of the key stakeholders that these reports will be sent to, and our role as Quality Management Directorate is to support the facilities to be able to close the gaps that have been identified during the inspection. And I would also want to take advantage to transition to one of the questions that was asked, that our involvement in this work, following up what has come out from the inspection, makes us responsive and not preventing issues that are happening within the health sector. I think just to inform the participants of the webinar that as quality management, this is just a small a part of the work that we've been facilitating, but primarily our role in the Ministry of Health Malawi is to develop or review quality of care standards, and these quality of care standards are optimal standards. They are beyond the minimum standards that are being enforced by regulatory bodies. So we go beyond those standards, and we also conduct internal quality assurance, and we go further and also support facilities, empowering them so that they should be able to apply quality improvement tools to close the gaps that that have been identified at the end of the internal quality assurance activities that we are doing. But we also understand the role for regulatory bodies in ensuring that we are implementing or we are advancing quality of care in the facilities. Thank you. Over to Hester.
Thank you so much. We're moving in very well. I wanted to invite Chrissy or Tondera if you have any additions, but you can also talk to this question that is asking about how you make regulatory bodies more friendly to practitioners and create an environment of mutual trust. I'm sure this is coming from the notion that regulatory bodies are seen as police officers who come to police and, infect rules and whatnot. How do you respond to this question, among adding to what Richard and Dr. Bongani have already responded to? Over.
Hello.
Yeah.
Yeah, I think I'll start on this. I think as regulators, it's just unfortunate that maybe we might be viewed as if we would always like to punish people, but we've got a bigger role to play in terms of advisory with respect to the areas that we are regulating. However, as it was said that there are some other issues, that non-compliances that may force the regulator to pose certain actions, like as it was indicated with the Medical Council to say that there are some other non-compliances that may lead to even closure of the facilities. So it's not just on the first encounter that you would want to close the facilities, but we've got an advisory role. When we inspect the facilities, we note that there are some non-compliances, we advise and possibly recommend some actions that would be done so that we should be in good terms with those facilities that we are, the stakeholders that we are regulating. Thank you.
Thanks. In addition, Tim, and as you're responding, there is also another question on the sufficient funds for prevention and alerts for violence and abuse. I'm sure this is an issue that we all want to talk to. So over to you, Tim.
Hello.
Go ahead, Richard.
Yeah, I just wanted to add to what Chris Echuru said, to say these things are usually raised up. They're usually said in different forums, to say regulatory bodies, when they hear that there is a medical council, they see that maybe it's an adversary. Contrary to that, we value practitioners as our main stakeholder, apart from the patients themselves and the public. And we have that responsibility of protecting the public from harm, including protecting the patients, and also to ensure that our practitioners, the working environment they have an enabling working environment. So we usually view practitioners as our main stakeholder, because we understand that the bipartisan approach usually doesn't work. So we cannot be in every hospital every time, and we depend on leaders within the profession to promote professionalism and to report malpractices and to report in non-compliance from proprietors in terms of, to say they should be loyal to the safety of the patients, and then they should be able to report it. But without us being in good terms with the practitioners, then obviously patients will be harmed, because individuals will not be willing to report. So I just wanted to say, for us, we have that engagement with, as regulators, we engage the practitioners in terms of continuous professional.
Thank you so much. Olive, do you have another?
Thank you so much. This has been just excellent, and we are already at time, unfortunately. And so I'm going to just quickly ask each panelist. We've heard so many important comments today. I'd like to ask each panelist in turn, if you could share with us just one word from what you take from this important joint collaboration. My word is efficiency. I hear that coming out loud and clear. Could I ask you, Dr. Pangani, what's your one word from this important collaboration on joint inspection? Do we have you, Dr. Pangani? Oh, it looks like Pangani.
Yes. Olive, you have just mentioned the word that I wanted to mention. It's also efficiency.
Okay, great. Okay, we're on the same page. It's certainly efficient, isn't it? Richard, what's your one word from this experience?
It's interregulatory collaboration for me.
Excellent. Okay, so the collaboration, is really, you're getting a lot from that. Excellent. Salman, working on all the data. What's your one word?
Probably my one word would be effective too.
Great. Chrissy, do you have a word?
One is so difficult, because I would love to combine collaboration, because in collaboration brings in the efficiency part of it. Thank you.
Okay, great. Okay, and Montandera, do you have one word?
Tondera is having challenges with her internet. She just sent a message.
Oh,
so I'm surprised if she's not responding.
That's okay. Okay. Well, it feels like there's a mutual feeling of efficiency, collaboration, and effectiveness. So, and that came across very clearly in the presentation. We thank you so much for sharing with us. this experience. This is novel, and this is experience that many others may want to learn from and hear more. If there's further questions from the audience, you can share them with us. We will share them with our speakers here today. We're going to say goodbye for now. The presentation, the recording and the slide deck, we will be sharing it on our Quality of Care Network website. Please join us there. We are very pleased to have had this presentation today. We look forward to continuing to sharing all this wonderful learning progress that's happening in Malawi. Our next webinar will in fact be at the Align MNH Collective next week on April 6th. The Quality of Care track will be happening on the 3rd day of the collective. So join us there and stay in touch. Take care. Thank you so much.
Thank you.
Thank you.
Thank you, bye.